Colleagues, a very good afternoon to you. Thank you so much for joining us once again for this World Health Organization Africa region online briefing in collaboration with APO Group. It is a fortnightly briefing where we give you an update of the COVID-19 situation in Africa. I'm Tsipiso Mapuitla. Welcome. The WHO briefing is being broadcast live in 2 languages, English and French. So please choose your language preference. That's on the globe icon there at the bottom of the Zoom app. So please, if you want it on English, choose that. French, do it on that. Francois?
Yes, hello, bonjour et merci d'être présent pour ce point de presse. Vous pouvez choisir la langue dans laquelle vous souhaitez entendre la conférence en utilisant l'outil d'interprétation de Zoom qui est le petit globe dans les options et vous pouvez choisir anglais ou français. Merci.
Okay, so colleagues, as usual, please remember to use the Q&A function on your Zoom app if you want to ask a question. I know some of you have already sent in questions. Please also indicate to whom you want to pose the question to, whom you represent, and also introduce yourself. So that is very, very important that you do that. So colleagues, as you know, Africa is not one country. It is a continent of disparate fortunes and challenges. And today we're going to look at the COVID-19 situations on the continent and case studies of 2 countries. We're looking at Rwanda and Niger. You'll hear from both countries what their experiences have been. So before we carry on with the briefing, let me please introduce the esteemed panel. Joining us from Brazzaville, Congo is Dr. Matsidi Somwetu, who's the WHO Regional Director for Africa, whom you know. She is joined by Dr. Michel Yao, who's the Emergency Operations Manager at WHO Africa. He'll be on standby to answer questions. And Niamey, let's say a warm welcome to the Honorable Dr. Idi Ilyasu Mainasara, who's Niger's Minister of Public Health. Joining us from Rwanda, the Honorable Dr. Daniel Ngamije, the Minister of Health. So let's get this off to a good start. To my panelists, please do keep to the time allotted to you, 2-3 minutes, so that we can have as many questions from the press as possible. Dr. Mweti, let's start with you. We know that Africa was nearing that 1 million mark. What is the status quo as we speak?
Yes, thank you very much. Partner the APO in enabling this conversation with journalists. Thank you everybody for joining us, and good afternoon. I'm very pleased to welcome Monsieur le Ministre de la Santé Publique de la République du Niger, Dr. Idi Ilyasu Mainasara. Soyez le bienvenu, Monsieur le Ministre, and also the Honorable Minister of Health in Rwanda, Dr. Daniel Ngamije. Welcome, Minister. Today, we'd like to take stock of the persistent and emerging challenges in the COVID-19 response, as well as the solutions that we are seeing across the countries in the continent. And I'd like to commend the honorable ministers for the strong and dedicated action in your countries. You have encountered some challenges. We had a surge of cases in Niger some time ago, and you were able to work on it and reduce the number. I'm sure both ministers will share more details with us of some of the innovations and some of the approaches that they've taken. At a time when governments are easing lockdown measures, the realization is dawning strongly that we will have to live with this virus for some time. There are now almost 1 million reported cases of COVID-19 in Africa, so we have not yet reached that milestone, and over 21,000 people have sadly lost their lives. South Africa remains the worst affected country on the continent and is now the 5th most affected country globally. In partnership with the Department of Health in South Africa, WHO is deploying more than 40 regional experts to provide support at the national and provincial levels in the country. Overall, the cases on the African continent account for 5% of the global total, and I'm often asked whether they reflect the true picture of the epidemic or not. One of the constant and concerning challenges in many African countries is a shortage of kits to test people for COVID-19. At the same time, some countries have increased their testing per capita while maintaining a low positivity rate, countries such as Mauritius, Rwanda, Cabo Verde, and Botswana. Through the UN Supply Portal, we're supporting countries to replenish test kits and other commodities. This area of access to new technologies, including also future vaccines and treatments, is one in which international solidarity remains absolutely vital. Through the COVAX platform, we are working with Gavi, the Vaccine Alliance, and other partners with a strong emphasis on equity in access to these commodities. We are starting also to work with governments and national regulatory authorities to be ready to roll out when a vaccine becomes available. So this readiness is extremely important. Countries and communities are leading the way in advancing solutions to many of the challenges in this response, and we will hear some of the examples from Nigeria, for example. The advocacy of community leaders encouraged more people to seek testing. In Mauritania, university students are helping to ramp up surveillance. Kenya trained over 79,000 community health workers and 15,000 youth champions who have raised awareness among 17 million people through household visits and other activities. So from Benin to Zimbabwe, countries are integrating COVID-19 in polio geographic information systems to provide real-time information for decision-making. So far, WHO has helped to strengthen the skills of more than 70,000 health workers in collaboration with regional and national professional associations. And Cote d'Ivoire, for example, has cascaded training to around 10,000 health workers in all of its 113 health districts. We are continuing to work with local authorities to expand public health capacities, including more than 30 countries that have decentralized lab or laboratory testing capacities. As I said, countries are opening up borders, and there are challenges in detecting and managing imported cases and sustaining the intensity of these public health measures as economic activities resume. Through our individual actions and choices, we as people all play a key role in solving these challenges. So in closing, I ask that you continue to join me in practicing and promoting the life-saving preventive actions. Wearing a mask and wearing it correctly so it actually covers your nose as well as your chin and mouth, washing our hands frequently, and keeping a distance. I recognize that African households need support beyond the health sector to be able to play their part, especially low-income households. So I appeal to governments and international partners to provide the support. Thank you. I look forward very much to our conversation today.
Thank you very much, Dr. Mweti. As you say, Africa at this moment accounting for 5% of the global infections, but the worrying thing, as you say, is the lack of testing. Let's hear now how Niger has had to deal with the challenges facing it. I know there are multiple challenges there. So Honorable Dr. Idi Ilyasu Mainasara is the Niger's Minister of Public Health. Please talk to us about the challenges that you've had, if you found any solutions thus far.
Merci. Bonjour, Dr. Mweti. En tout cas, c'est un honneur pour le Niger d'être présent à cette vidéoconférence. Merci. Les stratégies que le Niger a utilisées pour gérer cette pandémie, d'abord, il faut noter l'engagement politique au plus haut niveau et qui a permis la mise en place dès les premiers cas enregistrés en Afrique, en dehors du Niger, d'un comité interministériel d'orientation qui est présidé par le président de la République en personne. Et au-dessous de ce comité, il y a eu la mise en place d'un comité interministériel de gestion qui est dirigé par le Premier ministre chef de gouvernement. Et à côté de ces deux grands comités, il y a eu des comités ou des cellules techniques d'appui. C'est entre autres le comité scientifique qui est dirigé par le recteur de l'université de Niamey, Et vous avez un autre comité qui est dirigé par les religieux, le président de l'association, excusez-moi, le président de l'association islamique du Niger, le Monseigneur Lampo, qui est représentant des églises du Niger, et tous les comités techniques auxquels sont rattachés plusieurs sous-commissions, sous-commission riposte, sous-commission prise en charge, sous-commission communication, etc., etc. C'est en somme près de 15 comités de gestion qui ont été mis en place au Niger. Après la mise en place de ce comité, il y a eu l'élaboration d'un plan de riposte à la pandémie et la mise en place de l'élaboration de ce plan de riposte. Après ce plan de riposte, il y a eu la réunion, la table ronde qui a regroupé tous les bailleurs de fonds et tous les partenaires techniques, tout ce qui est système des Nations Unies, en particulier l'OMS et les autres organisations sous-régionales telles que l'OAS. Il y a eu l'appui financier dès le départ de l'État et le financement, en tout cas, du plan de riposte par les partenaires techniques et financiers. Il y a eu également une forte implication dans le suivi de la coordination de la mise en œuvre de ce plan de riposte. Il y a également la coordination multisectorielle et multidisciplinaire et une forte implication de tous les acteurs du système des Nations Unies et la mise en place d'une plateforme d'échange par visioconférence entre le gouvernement, le système des Nations Unies, les diplomates qui sont accrédités au Niger et d'autres personnes ressources qui ont en tout cas partagé leur expérience par rapport à la gestion des épidémies. Il y a eu la prise de décision d'orientation qui était basée sur les avis techniques, comme je vous l'ai dit, et il y a un comité scientifique qui regroupe d'éminentes personnalités. Il y a un comité technique qui regroupe plusieurs acteurs, les ministres, l'OMS, en tout cas tous les acteurs dont on pense qu'ils peuvent apporter un plus par rapport à la gestion de cette pandémie ont été impliqués. Et après cela, donc 39 mesures ont été prises par le gouvernement en vue de freiner et d'arrêter la propagation de cette maladie. Je ne vais pas les citer toutes, mais permettez-moi quand même de citer quelques-unes. C'est le cas de la fermeture des frontières, des écoles, des lieux de culte. L'état d'urgence qui a été déclaré actuellement, on vit en état d'urgence. Il y a le couvre-feu et il y a l'interdiction de tout rassemblement. Il y a les mesures de barrière, la protection l'utilisation des bavettes, l'utilisation en tout cas des moyens de protection individuelle, la distanciation sociale, etc. Il y a eu l'élaboration et la diffusion des mesures stratégiques au niveau des 8 régions du Niger. Et on a également révisé la stratégie qui consiste en tout cas à améliorer les alertes, à la définition des cas, la mise en place d'un centre de gestion des alertes, le suivi physique électronique des contacts, le respect des mesures de lutte par le pôle d'administration, le système des Nations Unies, qui ont en tout cas beaucoup contribué à la réduction des cas. Il y a eu également la mise en place d'un système de confinement rigoureux des contacts, puis des voyageurs entrant des lieux spéciaux dédiés par l'État. Il y a le test à l'arrivée et le test au 14e jour après le confinement, puisqu'on avait opté dès le départ pour un confinement de 2 semaines pour tous celui qui revient, en tout cas de la zone d'épidémie, ou tout celui qui revient, en tout cas qui rentre au Niger. Les dispositions de confinement ont été prises. Il y a la mise en place en collaboration avec le système des Nations Unies et les stratégies du confinement obligatoire systématique au niveau des hôtels qui ont été dédiés, soit c'est des hôtels réquisitionnés par le gouvernement, mais il y a également des hôtels qui ont été loués par du privé dans la gestion de cette épidémie. Et il faut surtout noter l'engouement vraiment de ces partenaires de proximité qui nous ont accompagnés. Il y a eu d'autres stratégies comme la production locale des bavettes qui sont destinées à l'usage de la population. Et c'est des bavettes qui ont été certifiées, en tout cas par le comité d'experts, surtout avec l'appui de l'OMS qui nous a aidés à étudier la qualité et la fiabilité de ces bavettes avant de demander à nos producteurs locaux de le produire. Nous avons élaboré et produit environ 7 millions de bavettes qu'on a mis gratuitement à la disposition de tous les élèves, en tout cas du secondaire jusqu'aux universités, qu'elles soient en tout cas les structures scolaires publiques ou privées, les enseignants, etc. Il y a eu la distribution des bavettes, et surtout les bavettes médicales au niveau des structures de santé pour continuer, pour assurer la continuité de soins, parce qu'on s'était dit que cette maladie, il faut vivre avec, et pour cette raison, il faut mettre à la disposition de tous les agents de santé les bavettes. Et nous mettons chaque mois plus de 1,4 million, plus de 1,4 million bavettes pour protéger les agents de santé, pour leur permettre de continuer les activités de la routine. Nous avons mis en place tout un paquet, en tout cas, de la gestion communautaire de cette pandémie.
Dr. Maina, sorry,
apparemment, j'ai épuisé les 3 minutes. J'ai épuisé les 3 minutes.
I think you have, Dr. Maina, Sarah. So if you'll allow me to just thank you for that contribution, emphasizing the importance
nous avoir permis de donner tous ces éléments d'appréciation.
Thank you, Dr. Maina Sarah. I assure you that there will be ample opportunity to expand a little bit more about that multidisciplinary approach that you have taken, and questions have already come through so that you can speak a little bit more about that. So thank you very much. Let's hear a little bit more now from Rwanda's experience. You know, Rwanda has almost double the positive cases of Niger, but very minuscule deaths. Honorable Minister Ngamijie is going to speak to us now about how Rwanda has been handling the COVID-19 response. That started very early, I think from January, isn't it, Dr. Ngamijie?
Thank you. Good afternoon. I'm honored as well to be on this platform for sharing Rwanda experience. I will start by thanks to Dr. Moeti, the Regional Director of WHO, and colleagues who are on this video conference as we share our experience. So basically, we had our first case, as you know, on 14th March 2020. And so far, we are with 2,104 cases, confirmed cases, and 1,237 were discharged. And we remain in our treatment centers with 862 patients in different treatment centers in the country. So far, we reported 5 deaths. So as my colleague from Niger said, we set also similar structures for containing this pandemic from the national level up to the lowest level at the district level. And we also developed a preparedness and response plan costing $73 million for the first 6 months. We are planning to revisit it again and extend it up to December. I want just to share some key achievement that, in addition to what my colleague said. First, it's about the decentralization of COVID-19 response. We came to realize that at the beginning, our response was driven by the central government, at the central level from the Ministry of Health. And it appears that we could not sustain that kind of interventions initiated from the central level. That's why we decided to decentralize COVID-19 response. And we did it by reinforcing structures of COVID-19 response at the district level, making sure that all these structures are effectively functioning. We provided guidelines how they should function, and we provide technical support, especially in increasing their capacity for testing COVID-19. We started with one national referral lab able to test COVID-19 in February 2020. Today, we are with 10 sites in the country where COVID-19 can be tested. We also reinforce capacity for case management, because we came to realize that with community transmission which occurred in one district in West Province of this country, we could not rely on capacity from the central level people to go and facilitate the treatment of people admitted in those treatment centers. And then we strengthened the capacity of clinicians at this treatment center to be able to manage COVID-19 confirmed cases. Thinking that it can happen in more than 2 or 3 districts, the conclusion was like we should start to test home-based management of COVID-19. And we are starting piloting the model to see whether this can be feasible in some settings, in some household, depending criteria that we set. And once we check and we realize that a setting or a household is meeting those criteria, we are testing this possibility of treating COVID-19 at home without necessarily picking the person to a treatment center. Because after 6 months of this pandemic in the country, government is making a lot of expenditure, and it's a lot of pressure to the health system. We should be anticipating ahead what might happen if there is generalized community transmission. We should already thinking how to contain and manage a scenario of generalized community transmission if it's happened. What also we did is to optimize testing processes. You know, the shortage of kits on the market. If we are doing like a community survey in environment where we have low incidence of COVID, we do a pool testing system so that we consume less kits while getting results quickly, and then we are able to take some decision to contain or to guide decisions for containing COVID-19 pandemic. A second point of experience I want to share with you is the use of technology to guide our response. Of course, COVID-19 is transmitted through contact between a person who is infected and another one who is not yet infected. So trying to reduce all means that can reduce transmission was the objective for us. And we came to realize that financial transaction by exchanging money was also one of the sources of transmitting this disease. So the government encouraged that we use mobile money cashless system by facilitating operating companies of telecommunication to not charge those transactions, at least reducing the cost of transaction so that people can get advantage of not necessarily doing their transaction by exchanging money, but they can do payment or transfer of money using technology. What also we did was to try to reduce the use of papers in different interventions we are doing. Like when we are doing tracing of cases, initially we used to fill some forms, and those also could be a vector for transmission of the disease, or just bring a lot of work. Then we went through a system of using iPad and mobile phone for collecting information, especially when we are doing our tracing of suspected or contact of people who are infected. So we can use those, we have an app which can be used through those iPad or a telephone, smartphone, even where there is no connection. Then later on, information can be stored and analyzed when a person is joining a place where there is connection.
Dr.
So
Ngami, thank you very much.
I'm delaying. Okay, let me go quickly. So this was very helpful, at least for investigation teams. And we also use this technology to reduce transmission of the disease among health personnel by using robots and other tools like drones for community awareness, while using drones for the transmission of different messages. And also in our command posts, we were using data visualization systems so that it became more easy to see in different settings where you have a lot of increase of incidence of the disease. And it's more easy to explain it to decision makers and to the population where you are displaying a map of the country, and then you can show them that in this sector or in this village, you can see increase of cases just in a visual manner. It became more easy to understand, and then to go for decision like for lockdown, etc. People will just feel why you are putting these villages in lockdown and keep the other ones without being in lockdown. I think for now, this is some experience that I can share with you. For the rest, we can probably give additional information through questions. Thank you.
So much. Thank you so much, Dr. Ngamichi. I think there's a lot of interesting things that came out of that, especially the home-based management system and how you are optimizing testing. I think a lot of us would like to hear more about that. But we already do have questions coming in from my colleagues. So please allow me to have the first question come through from my colleague here in South Africa, Tamar Khan from Business Day. You've got some questions. If I could just allow you to ask yours.
Hi there. Thanks very much. My question is to Dr. Moeti. And firstly, I wondered if you could comment on why the WHO team is only going into South Africa now after it's recorded more than 500,000 cases. And there are some signs that infections are plateauing in some provinces. So it raises the question, would it not have been better to go in sooner and help prevent the virus taking hold in the way it has? And secondly, in your view, what aspect of South Africa's response to the coronavirus pandemic requires the most urgent attention? Thank you.
Thank you, Tamar. Dr. Moeti?
Yes, thank you. Thank you very much for that question. Well, first of all, I think we have sent a team to South Africa, of which 15 people arrived early this morning. But, you know, WHO has always been present in South Africa. We have a local team. We have a WHO office, a leader, the WHO representative, and we had in fact mobilized quite a number of local experts. So we have our own staff. Our own staff in our office were repurposed to work in support of the government and the country, and then we recruited additional experts. And, you know, at a certain point in time, it was not possible to move anybody anywhere. We had many staff stuck on routes, on mission, people who were going to various places because of the very strict lockdowns that had been imposed by countries. And it is now, as these lockdowns have started to be relaxed and as the situation in South Africa has started to become so serious, that we have been able to mobilize and to send this team into the country. And as to which aspects of the response need strengthening, well, certainly we've seen that there are several severely affected provinces in South Africa. One of the most important understandings we have is that there is need for better capacity at the local level, at the district level, and in provinces. So what we are doing with this team is we will, with the Department of Health, be deploying them around several of the most severely affected provinces to support the management in areas such as epidemiology, surveillance, data analysis. We know that one of the most important things is for the data to be first for the results to be available quickly in terms of laboratory testing, and then for the data to be analyzed quickly in order to guide action. We've also got people who are going in to support other areas like risk communication, ensuring that they work with local authorities, local experts, and our team from the country office to enable the communication with people to be decentralized, to be localized, to be through local organizations, associations, but to make sure that the core messaging is kept accurate. At the provincial district level, we're going to support coordination. I think you've heard the way particularly the minister from Niger described, and it's similar in South Africa. There are many players who are involved in this work. And one of the key roles of the government, the provincial health leadership, is to work with all of these and make sure that everybody is doing their part adequately so as to have the most impact. Thank you.
Thank you very much, Dr. Moeti. So interesting that you speak about decentralization. Rwanda earlier on speaking about how centralization was very pivotal to its management. We've got a question here from Vincent Cassano from KT Radio in Rwanda. Now, his question is about how he feels many countries are not taking preventative measures seriously and how this is likely to affect their neighbors. So, Dr. Gamajie, if I could ask you to answer this question, please.
Yeah, for the decentralization, as I explained, our first cases occurred in Kigali, and then the first cluster of cases were in Kigali, and later on with regional cross-border transport, we had cases out of Kigali, especially in the west part of the country. So, and as I said, the first community transmission we had occurred in Rusizi district, close to Bukavu city in DRC. It's far from Kigali, 300 kilometers from Kigali. So, and then some sporadic cases appearing here and there. So basically decentralizing the response was required because we could not bring teams from the central level and go and intervene in any district. This was done at the beginning, but it was not sustainable. And we don't know when this disease will be, this pandemic will be out of the country, even the world. So we are going to with solutions that are sustainable. And then for having those solutions, for having a solution which is sustainable, the centralization of the entire team, the centralization of capacity to the district level was for us a key decision to strengthen teams where they are at the district level so that they can respond properly. This is what we did. For the second question, I didn't catch it well, if you could repeat it.
So Dr. Ngamije, very briefly, so do you think that your preventative measures have helped secure your neighbors?
Yes, I think I can say yes, because we had different clusters appearing here and there, but so far, at least in Rwanda, we can say that the only community transmission we had was in Rusizi, and today 4 sectors which initially were under lockdown are now are no longer in the lockdown. If you analyze the trend of cases in that district, there is massive reduction of cases, and we try with different measures in place to contain any arrival of imported cases. And even when people are traveling from Rwanda now, because we opened our airspace, we have strict measures to test them before traveling. So we are trying to avoid any new imported cases, and we avoid also to export cases while we contain transmission of the disease in the country itself.
Right. Thank you so much, Dr. Ngamije. We've got a similar question from James Amadou from Radio Television Niger. So this will be to Niger to answer. And the question here, Dr. Maina Sarah, is basically about compliance. And what is the strategy of the Niger government to deal with it? Dr. Mainasari, did you get that question?
Reprends la question. Non, reprends la question.
Okay, so the question is about compliance and what the Niger government is doing. What is the strategy to deal with this non-compliance?
Merci. Et effectivement, le gouvernement s'est entouré de toutes les précautions pour que les 39 mesures que nous avons prises avant même l'apparition du premier cas au Niger qui est survenu le 19 mars, pris toutes les mesures pour mettre en œuvre ces mesures. Et la première grande mesure qui nous a permis d'appliquer les dispositions prises, c'est l'état d'urgence. En état d'urgence, si vous voulez, c'est presque une confiscation des libertés des individus, puisque c'est une situation de guerre, une situation de pandémie, c'est une situation de guerre. Et pour faire appliquer les mesures, il faut qu'on soit dans une disposition particulière. Et c'est ce qui nous a amené même à l'Assemblée nationale, devant les députés, pour faire le plaidoyer, pour expliquer la nécessité d'une loi qui sécurise les agents de santé qui font les traçages, qui font les dépistages, qui font les confinements des personnes contaminées, des personnes contacts, des personnes qui rentrent au pays contaminées. Et c'est ça qui nous a permis, en tout cas, de mettre en œuvre. Et pour vous assurer que dans la plupart des cas, ces mesures ont été respectées. C'est vrai, il y a des failles qui ont été observées par-ci, par-là, mais qu'on a pu rattraper par la suite. Et c'est ce qui nous a permis, en tout cas, de limiter de façon très significative la propagation de cette pandémie. Je vous informe que le premier cas qui a été enregistré, c'était un cas importé, ce n'est pas un cas autochtone. Quand je dis importé, c'est un expatrié qui est arrivé au Niger et chez qui, en tout cas, le test a été positif et la contamination est partie de là. Mais également, il y a aussi les autres pays frontaliers, puisque le Niger fait partie des derniers pays qui ont eu à enregistrer des cas, alors que tous les pays frontaliers, déjà à l'époque, ont eu à enregistrer des cas. Et c'est ce qui a favorisé la contamination. Dieu merci, avec les précautions qu'on a prises, avec les précautions qu'on a imposées, même au niveau des frontières, cela a permis de réduire de façon significative. Il y a eu également le monitorage régulier au cours desquels des réunions de comité sont tenues, puisque au même titre que mon collègue de Rwanda, on a mis un dispositif au niveau des 8 régions du Niger. Et c'est même le même dispositif qui a été mis au niveau des 72 districts sanitaires que compte le Niger. Et même au niveau des CSI, il y a eu des formations en cascade des agents de santé par rapport à la détection de cas, à la définition de cas, par rapport à la prise en charge de cas, mais surtout par rapport aux procédures de confinement. Puisque, vous savez, nous avons beaucoup de frontières, par exemple, avec le Mali, avec la Libye, avec l'Algérie, où il y a des réfugiés. Durant la première phase, la première apparition de cette maladie, nous avons eu à faire face à des milliers de réfugiés qui reviennent au Niger ou qui traversent le Niger pour regagner leur pays. Il va falloir prendre en compte cet aspect, confiner ces réfugiés et les tester avant de le faire continuer pour éviter l'exportation de cette maladie dans leur région ou bien pour éviter la propagation de cette maladie dans notre pays.
Thank you so much, Dr. Mainasari. And I think that's something I'd like us to talk about a little bit later on, the insecurity in Niger and how that's impacting on your efforts. But we've got a question here from Susan Njanji from AFP in South Africa, and it's posed to you, Dr. Mwedi. It's about the number of healthcare worker infections in Africa, especially in South Africa as the epicenter, and also just on South Africa, the fact that the number of positive cases are starting to decline, and if that's mirrored in any of the other African countries. Dr. Mwedi? Dr. Mwedi, did you hear those questions posed to you? Okay, I think maybe Dr. Mwedi's video is frozen. Let's see if we can just come back to the next question, and then we'll see if we can get Dr. Mwedi back on the line. But perhaps if we can get the country experiences of both Niger and Rwanda very briefly. Rwanda specifically has negligible number of deaths, Dr. Ngamije, but in terms of healthcare worker infections, how many do you have? Just very, very briefly, please, Dr. Ngamije.
Thank you. We have a very few number of health personnel who were infected with COVID-19. I think they are less than 10 because we deployed all PPP measures, and different measures were taken to avoid that health personnel being contaminated with this disease. We use also robots to reduce contact of health personnel with patients. Those robots are helping us to collect some information, temperature, and other information in treatment centers. And so basically, we don't have big issue really of health personnel affected by COVID-19 so far.
Thank you so much, Dr. Ngamije. So we've got another question here from Ibrahim Yero. So I'd like to ask Dr. Michelle Yao to answer this question. And the question is about how the WHO predicted catastrophe in Africa, but obviously that's not happening, given that Dr. Mwedi says so far we only account for 5% of the infections. But what explanation does the WHO give for the earlier prediction? And just talk a little bit more about the resurgence of the pandemic around the world, please. What do you foresee for Africa? This is a question. Dr. Michelle Yao?
Thank you very much. In fact, the predictions are based on different scenarios. So the scenario used is a wide community transmission with also the response capacity that we had at the beginning of this outbreak that was a bit worry for us that the system could be easily overwhelmed and the disease could spread faster. So this was an element taken into account for this prediction. But of course, African countries took confinement measures earlier, closing school, as well as also limitation of movement. All this reduced the spread. So scenario did not happen, but is still not out of context in many countries. If measures have not taken, we can see when these confinement measures were eased, an increase that we observe in many countries. At least these measures helped to build some capacity. We had quite an increase in the treatment capacity as well as in the laboratory capacity. So our call was a kind of alert of something that could happen if countries are not mobilized and not taking the right action. So we are pleased to see that it did not happen, but it's not over yet. And it's why some of the measures, preventive measures, need to be reinforced. Is to what we notice in many countries that people are no more using masks or are not observing physical distancing. At the same time, countries should continue working. Decentralizing is critical. In fact, anticipating to avoid a worse scenario. Over to you.
Thank you, Dr. Yao. We do have Dr. Mwedi back on the line with us. Dr. Mwedi, there was a question for you earlier on from Suzanne Nijanji from AFP South Africa. It's about healthcare workers, the number of infections in Africa, and that is Africa as in general, but also South Africa as the epicenter. And Susan also wants to know about the daily infections. Seeing that they're going down in South Africa, we've seen a decline in recent days. She says, does that mean that this is likely to be mirrored in other countries as well? Dr. Moeti?
Okay, thank you. Sorry about that. We are having sometimes connection problems here in Brazzaville. So we've found a way of getting some information from countries about the number of healthcare workers that are infected. And we've had so far feedback from 41 out of our 47 countries in the region, and indicating that about 35,000 healthcare workers are infected. So South Africa clearly has the majority of healthcare workers who are infected at 24,000, a quite significant proportion of these healthcare workers who are infected. And indeed, we have started to see a decline in the daily number of cases in South Africa. I heard the Minister of Health, Minister Zweli Mkhize, saying a couple of days ago that, yes, this is something that's starting, but we need to observe it for a little bit longer before we say firmly that this is a trend. There are a number of other countries that are seeing a similar decreases to a similar degree, about 20% fewer cases the last week than had been the week before. And these include countries like Nigeria, Cote d'Ivoire, Cameroon, the Republic of Congo, where we are, Mauritania, the Democratic Republic of Congo, Central African Republic, and then several Southern African countries, Botswana, and some West African countries like Liberia and Benin. So we do have countries where, despite the fact that the governments did a relaxation of the measures, there was an initial increase in cases in several of these countries. Now we're starting to see a decline. I think what the take home is that we need to monitor this and just assure ourselves that this decline continues, that it's sustained. Thank you.
Thank you, Dr. Moeti. This next question is for Dr. Ngamije. It's from, let me read it. It's from Ivan Mugisha from the East African newspaper. And basically, it's speaking about how Rwanda is seeing the number of cases decline to almost 10. And he wants to know, what are the prospects then of the reopening, not only of the economy, but also other aspects of social life, school, etc., etc. Dr. Ngamije?
Thank you. The cases are not decreasing so much as we wish. I think for the last 2 days, it's really good. But for the last week and before that, we had a certain number of cases, around 20, 30 cases per day. It's only the last 2 days where we have a few cases. We hope this trend, if this could continue, that would be okay. So, and it is in that perspective that different measures were taken to resume different activities, including churches reopening, and different business reopening as well, including the opening of air border, the airport of Kigali. So far, schools are not yet opened. We do still watching the situation at the end of this month to see what will happen. So decisions are taken depending the trend of the incidents. And for sure, if everything continues to go well like we wish, additional decision will be taken. But so far, we stick on those decisions that were taken. The last one was the opening of the airport of Kigali.
Thank you very much, Dr. Ngamije. We've got a question here saying that with countries like the US pumping millions of dollars towards manufacturing COVID-19 vaccines, it's clear that Africa not only needs to carry out its own efficacy and effectiveness study, but align itself with a country or companies that will see the continent also get the vaccine on time. So the WHO has spoken about this. If I could just also perhaps bring in Dr. Manasara to talk about this, we'll come back to you, Dr. Moeti. But just what are the challenges? I know testing challenges were mentioned earlier on. How are you overcoming this? How are you capitalizing, optimizing your resources, Dr. Sarah?
Merci. Effectivement, nous avons des défis dont les principaux tournent autour du déni de la maladie, surtout des fausses informations qui ont circulé sur les différents réseaux sociaux par rapport à cette maladie. Il y a un autre grand défi, la réouverture des frontières. Nous venons le 1er août d'ouvrir nos différentes frontières surtout aérienne, au niveau de la capitale à Niamey, à Agadez et à Zender. Il va falloir mobiliser beaucoup de moyens parce qu'il y a des conditions qui ont été fixées pour, par exemple, l'arrivée d'un passager au Niger. Il doit présenter un test valide d'au moins 72 heures et si il n'a pas de test, il doit payer pour que le test lui soit assuré. Mais si le test est valide, il continue vraiment son chemin et on donne des conseils d'autoconfinement. Si c'est quelqu'un qui doit quitter le Niger vers l'extérieur, là également, il doit présenter un test PCR valide d'au moins 72 heures pour éviter l'exportation de ce virus vers l'extérieur. Et il y a un autre défi, c'est par rapport à l'insuffisance des respects des mesures de barrière. Là, la sensibilisation continue. On est en train d'intensifier la sensibilisation à tous les niveaux parce que, comme je l'ai dit, il va falloir apprendre à vivre avec cette maladie. Donc, les mesures barrières s'imposent à tous aujourd'hui à partir du moment où les frontières aériennes sont en train d'être réouvertes dans tous les pays du monde. Donc, les mesures barrières s'imposent. Et il y a la difficulté de contrôle des points d'entrée, parce que quand vous prenez nos pays africains, on a ici en Afrique, je dis de façon particulière ici au Niger, nous avons au moins 15 points d'entrée terrestres, même si la voie terrestre n'est pas ouverte, mais quand même, il y a des gens qui cherchent tous les jours à faufiler. Il y a également, à l'occasion de la saison pluvieuse, les gens qui cherchent à regagner le pays par voie terrestre. Tous ces gens, il faut essayer de les confiner, il faut les tester avant de les laisser continuer, en tout cas au niveau des villages. Tout ça, c'est des défis aujourd'hui qui demandent beaucoup de moyens et avec l'appui des partenaires, en particulier l'OIM, qui nous aide à reprendre, à prendre en charge certains migrants, certains retournés, et pour faire en sorte que ces gens soient testés, soient pris en charge, soient confinés, et qu'après le confinement, qu'on puisse les tester, s'ils sont négatifs, ils continuent leur chemin. En résumé, c'est les principaux défis auxquels aujourd'hui on est confronté. L'autre grand défi, c'est la vaccination. La vaccination, même hier, à l'occasion d'un échange par visioconférence qu'on a eu avec l'Alliance Gavi, cette question a été posée. On pense que d'ici 2021, si le COVAX serait disponible et que ce COVAX soit disponible à tous nos pays africains. Là également, c'est un grand défi. Il va falloir une implication très forte des partenaires qui accompagnent nos États dans le cadre de la disponibilisation des vaccins dans nos différents espaces communautaires. Merci.
Thank you very much, Minister. And that question was, of course, from Elizabeth Merab of The Nation in Niger. So let's move on to this next question from Rhoda Adiambo from BBC Focus on Africa. So she's talking about malaria parasites in Rwanda becoming resistant to artemisinin. And if I could come to you, Dr. Gameje, to please answer this question. Are you experiencing this? And have you done any research on what is the cause of any such resistance?
Thank you. In 2018, 2019, we did a clinical trial. And we came to realize that in one clinical site, Masaka Health Center, we had some parasites, 19 parasite, 19 patients with parasite presenting gene mutation against Artemisia. So it was 19 patients out of 257 total patients that were under that clinical trial. So, but in terms of efficacy of the drug through that clinical trial, we do still have 95% of efficacy in terms of treatment rate. So we believe that the mutation is probably due to natural selection or natural, let's say, selection of for the parasite to survive due to the huge pressure of different measures are in place to contain or to contain this malaria. Because we did even assessment with other parasite in South Asia, in Mekong. These two types of parasite are different. So it's not imported parasite. It's definitely indigene mechanism from the parasite to try to survive due to the pressure with different measures in place, including treatment, prevention for malaria that we have in the country. So we are still watching the situation. We increase the surveillance, and we hope that we should be sharing information with other countries and probably get possibility of other countries also to monitor the situation, because probably we discovered it, but other countries might have also those kind of situation just because the system is not yet there to detect mutation of this gene against of parasite against Artemisia.
Thank you very much, Dr. Ngamije. Dr. Moeti, this next question is from Hudson Kutisa from the New Times in Rwanda, and it's basically talking about what he perceives as a lack of enthusiasm by Africans to be involved in vaccine trials. He asked whether if you foresee this as a problem and how else can you encourage them to buy into these vaccine trials. Is this what you're observing, Dr. Moeti?
Well, yes, what we observe so far is that we have only one African country, South Africa, which is already actively engaged in a vaccine trial. We knew that several other countries were in the pipeline. I know that Mali and a couple of others were considering this, and the work was being done to review how they could get involved in vaccine trials. As WHO, we strongly encourage the member states to be engaged in these trials so that we have the opportunity to see how these tools, the vaccines, work in African populations. We know, of course, in order to do that, you need volunteers. You need people to come forward and want to be subjects in the trial. And we are very concerned as well about the emerging, if you like, negative sentiments among African populations in some cases about participating in trials and vaccine trials in general, because in the early part of the pandemic, there were some discussions implying that African people were to be used as guinea pigs for the development of vaccines. And then most probably Africans, because of cost issues, would not even be able to benefit after the vaccines had been developed, would not be able to afford to have access to these vaccines. So this is part of kind of infodemic, as we call it, false information that is around, and we want very much to dispel these negative rumors. There are very strict guidelines under which these trials get conducted, and populations and countries that have been involved in the trials have the right to have access to these tools. These are the principles that we're very much promoting as WHO and as well as some of our partners at the international level. So we can only continue to encourage countries and very much the population to be interested in being part of discovering these tools, because it will be to our benefit.
Thank you, Dr. Moeti. Let's just get some final words from our panelists now. Dr. Ngamije, let me come to you to talk about the possible challenges that Rwanda may face. You've done very well in obviously being proactive from the beginning, but does that mean that the low numbers that we're seeing will continue? Do you fear a surge, as the question was asked earlier on, and how would you manage that? Just your final words in about a minute, please.
Thank you. I think challenges we are facing today is that in the region, for us, it appears that there are still a lot to do to harmonize and synchronize intervention in the region. We are still facing cross-border transmission, high risk of cross-border transmission with truck drivers who are serving in the region. This is one. Number two, as we open Kigali Airport, we are already starting to receive passengers, some of them coming with rapid test results. And while clearly we said we are just accepting only PCR tests, so it gives us additional burden for keeping them, testing them until we have their result negative. But as they travel, they will be with crew who are Rwandese, especially those coming with Rwanda from different countries. So this is a challenge. It's a challenge for, resume economy, but also preventing a new cluster from people traveling with different aircraft. These are big challenges that we are facing today. The other one is availability of all kits, especially as we use different platforms for testing COVID. Sometimes you have some platform without available kits on the market, although we want to buy, but you might spend like a month, 2 months waiting the arrival of those kits. So basically, these are big challenges that we are facing for now.
Well, thank you very much, Dr. Ngamija. Dr. Mainasara, just to hear from Niger, you mentioned earlier on, I know you also have challenges of malaria, malnutrition, but there's the insecurity that you're seeing in the Southeast and Southwest. How do you think that will impact on your COVID-19 positive incidence rates, and how are you going to manage that?
L'impact de tous ces facteurs, l'insécurité, la malnutrition et autres facteurs qui ont un coût sur le budget de l'État, parce que la prise en charge de la COVID sous-tend avoir des moyens suffisants pour faire face à tout le mécanisme de la prise en charge, à la mise en œuvre du plan de riposte. Le gouvernement, en tout cas, est en train de prendre des dispositions d'ores et déjà à l'occasion de la table ronde de mobilisation de ressources. Et pratiquement tous les partenaires qui se sont annoncés aujourd'hui sont en train de concrétiser leur appui envers le Niger. Et également, les autres partenaires techniques, durant pratiquement tout le mois, nous avons eu à réceptionner et tout ce qui est intrant, qui va de médicaments, de consommables, des moyens de protection, des moyens de détection, les tests rapides, les tests PCR. En tout cas, nous sommes en train de les assembler pour faire face, en tout cas, à la réouverture de ces frontières aériennes. Mais également, l'autre défi, c'est le suivi électronique, le suivi électronique pour faciliter le suivi de contact, pour faciliter l'autoconfinement. Parce qu'à partir du moment où on a ouvert les frontières aériennes et on a pris la décision d'autoconfiner, il faut qu'on fasse un suivi rapproché de tous les gens qui reviennent pour qu'au moindre doute, au moindre symptôme, qu'on puisse tester la personne, qu'on puisse au besoin prendre en charge la personne. Et l'autre défi auquel on doit faire face, c'est la mutualisation des efforts de l'espace CEDEAO. Parce que, comme vous le savez, il y a beaucoup de nos pays de l'espace CEDEAO, au nombre des 15, qui ont été confrontés aux mêmes réalités de gestion par rapport à la mise en œuvre de ces mesures. Lors de la 21e Assemblée générale des ministres de la santé de la CEDEAO qu'on a tenue avant-hier par visioconférence, des résolutions très fortes ont été prises pour mutualiser les efforts, pour faire en sorte que les ouvertures de ces aéroports soient synchronisées pour que le test PCR soit identique au niveau de notre espace, pour éviter l'exportation ou l'importation de cette maladie dans notre espace. Merci, merci.
Thank you very much, Dr. Maina. So, Dr. Michelle Oyal, let me ask you this question very briefly. The search teams Dr. Mwiti spoke about having arrived in South Africa. Is there a hope perhaps that they will help inform what else you do on the African continent? Will you learn more from the search team in South Africa on how to handle what's happening in other countries? You are welcome to answer this question in French.
Bon, le déploiement en Afrique du Sud, c'est un appui complémentaire par rapport à l'appui que l'OMS apporte depuis le début par la présence de son bureau. Et ces genres de missions, on apprend toujours. Cela nous permet d'identifier un peu qu'est-ce qu'on peut mieux faire pour accompagner les pays dans divers domaines. La directrice régionale a mentionné les aspects d'une analyse fine pour la décision de santé publique, mais aussi l'accompagnement dans la formation. Comment est-ce qu'on peut partir de là en ayant laissé sur place une capacité beaucoup mieux formée pour la suite de l'épidémie, mais aussi pour le futur. Donc, ce genre de déploiement nous permet de comprendre davantage la dynamique de l'épidémie, de partager les bonnes expériences, mais aussi de corriger notre approche et notre compréhension dans cette épidémie. Merci.
Thank you, Dr. Yao. Dr. Mwiti, let's end with you. The question was raised earlier on about the battle for resources. You mentioned the issue of the shortage of testing kits, but I think a lot of developing countries' concerns is the fact that they don't have the financial muscles that the developed countries do, that when there eventually is a vaccine, that will lag far behind. And I think that also goes in tandem with a question about, you know, the projections. We are at the 1 million mark. Does that mean that because of this, perhaps we'll see an exponential rise in cases? Just your final words on that, Dr. Mwiti.
Yes, I think first of all to the projections, you know, we had based our projections on a starting point of community spread, widespread community spread happening. So because of the early imposition of these very severe measures, that did not actually happen. So I think the course of the epidemic, of the pandemic in Africa has been quite different from what we had predicted, has been much less. It's difficult at the moment to say when it's going to peak. We think it's going to be here at a kind of slow burn, if you like, of the type that we are seeing in many countries. We're very encouraged to see the start of a reduction in some countries, even if there are some countries where, I think about 10 countries where there is an increase, but not exponential. So we think that the situation will continue to need a lot of effort, and we are very much then looking forward to the availability of a vaccine at some point, hopefully next year. And here to answer that second question, we're of course working in WHO with other multilateral partners, with some bilateral member states, African and Western and other, and globally, in fact, member states, to put in place a mechanism, a platform coordinated by Gavi, where all countries will be able to equitably have access to vaccine supplies once some vaccines become confirmed as being efficacious and safe. We also observe, of course, that some countries, some upper income countries are paying hundreds of millions of dollars to secure supplies of vaccine in advance. And we would like to hope that there will be a balanced approach to doing this with the same countries, because some of them have been involved in some of these multilateral mechanisms, really working with at the global level on a strong drive for equity in having access to these vaccines. The African Union, with the Africa CDC as the operational arm, has also mobilized African countries, mobilized financiers of access to vaccine to them. Then ourselves, as the African continent, do our part to make sure that we are engaging in these processes of putting money up front in order to make sure that Africa doesn't get left behind. This is an issue that I think merits close following up. It merits strong advocacy at the global level, at every level, for, if you like, global solidarity. I think it really does merit global solidarity for those who are able to pay in advance, to be aware as well that as long as we have countries whose populations are vulnerable, and as long as we continue to be such an interconnected world, then this will continue to be a problem for even those countries that manage to vaccinate many of their populations. And we've observed in some of those settings that there is a high degree of vaccine denial, and some surveys are showing that significant proportions of the people say they will not accept a vaccine even if it's not available. So it's a very much interconnected problem, and I hope that it can be addressed in that way among member states. Thank you.
Thank you, Dr. Moeti. And I certainly do agree that it's something that needs teasing out a bit more. There was a question earlier on about whether 15% of countries' budgets are enough to fight this pandemic. So we will, I'm sure, expand on that at another time. Thank you very much, Dr. Matshidiso Moeti, WHO Regional Director for Africa, who was joined by Dr. Michelle Yao, who's the Emergency Operations Manager in Niamey. Thank you very much to the Honorable Dr. Idi Iliaso Mainasara. And in Rwanda, the Honorable Dr. Daniel Ngamejia, the Minister of Health. Colleagues, thank you so much for joining us. And I do encourage you to please make use of the Q&A function to send your questions in early. Unfortunately, we can't deal with them all, but we'll keep on persevering. Thank you very much to all of you.